So good thing that the pulse ox is reliable. And then you can get a PCO2 and basically quality control your end tidal, right? If your PCO2 is 40 and your EMA is 38, then your EMA is pretty close, and you can just go off of that and not have to burn any more cartridges to tuning the ventilation mode and tuning the carbon dioxide mode on your ventilator.
Now, some of the machines, like your iStats, like they do some kind of math and algorithm and convert venous blood numbers and give you a representation of what they would be arterial. Like, is that reliable?
I don't know. I've never used it because anytime I'm getting an iStat for oxygenation, it's always arterial. So I don't know. I mean, I would say try it, trouble check it, quality control your SpO2, your pulse ox, but when in doubt, go with your SpO2 because you always want to get your data from the most primary source possible, the most direct measurement possible. So it's one of the reasons actually that, we get bicarbonate on an ABG, but bicarbonate on an ABG, bicarbonate, in your blood is not a directly measured value on the iStat. It's calculated. And, they'll have people come and say, oh, the bicarb is low. And I was like, well, did you get it on a blood gas or did you get it on a serum? I was like, oh, we got it on a blood gas because we were, adjusting the ventilator or adjusting the ECMO circuit. And I was like, and then you got it on a calculated one, on the directly measured one on a serum chemistry, and it's like 5 points higher or whatever. So, which is significant, right? It's like 25%. So I have a healthy skepticism about calculated values on any lab to include iStats.
Right. It's probably, I would imagine the calculation is going to be based on healthy people versus trauma people. So, right. So it's an estimate, just like most other things in medicine. We get our data off healthy people and try and extrapolate that to unhealthy people, and it's going to be off.
And then the only other... go ahead.
I was going to say, so like we're talking about different values to get, which has been great, but like how frequently are you drawing these? Are you doing it every 10 minutes, 30 minutes, an hour? Because that's a lot of labs. That's a lot of cartridges.
Correct. I don't think we draw labs as frequently as every once in a while. Maybe we'll draw something every hour. But we don't use labs that frequently. We use labs, and labs should be used to help establish an initial diagnosis of mechanism and severity, right? Because they add, like I said, they add data, right? If you've got somebody whose, mean arterial pressure is 40 and their pH is 7.4, that's a totally different pH. They're compensated. If you have somebody whose pH or whose, mean arterial pressure is 40 and their pH is 6.9, they're decompensated, totally different patient. Much more unstable. So that's your initial snapshot. And then if you are doing interventions that, can affect those initially bad looking labs and getting another set to reassess the effect of your interventions, would be reassuring. Then get a set after you do your interventions. And then after that, it really depends because especially in a, tactical environment, a resource limited environment, I would look for what else is altered when this patient looks bad and is looking better when this patient responds, and track those trends rather than keep sticking them for labs and burning cartridges, right? So I mean, that makes complete sense.